morning, everyone. Welcome to our Department of Psychiatry Morning Grand Rounds. This is the first in the series for this academic year. Before we get started, we'll start off with land acknowledgement. We acknowledge that the land on which we are gathered is the traditional territory of the Anishinaabe, Etowandron, Wendat, and Haudenosaunee peoples. This land is covered by the Upper Canada Treaties, and we are here in peace and walk with respect on this part of the turtle island that we call our place of work, home, and play, and walk alongside our Indigenous peoples. Just to remind everyone before we get started on the actual presentations, that please use the Q&A function for asking your questions, and the chat function for any other reasons that you do need to use it. Please make sure that this is a webinar webinar presentation, so your questions and answers will be in the read out when the presenters are ready to have the audience participate. I also want to remind that if you do want to ask a question, please raise your hand, and Kate will unmute you, and you will also be able to open up your video camera at that time and ask questions via that route. Of course, and finally, of course, fill the evaluation form at the end of the presentation, and make sure you sign in with your first and last name. If you're joining by phone, make sure you send an email to Kate so that she can capture your attendance. All right, we'll get started. It's my pleasure indeed today to introduce our guest speakers, which is Dr. Rob Nicolson and Dr. Agata Dzwonek. Dr. Dzwonek grew up mostly in Calgary, Alberta. She completed her undergraduate medical education at the University of Ottawa. She graduated from Ottawa Psychiatry Residency Program in this past year and recently moved to London to complete her fellowship in neurodevelopmental disorders. During her spare time, she's a full-time mom of two little yet very active and loud kids. She loves traveling overseas and camping with the family from May until September. Dr. Rob Nicolson is well known to all of you here in the audience. Dr. Nicolson is an associate professor in the Department of Psychiatry and chair of the Neurodevelopmental Disabilities program at Western University. Dr. Nicolson completed his medical school training at Western University before moving to the University of Toronto to do his residency in psychiatry. He worked as a visiting scientist in the child psychiatry branch of the National Institute of Mental Health in the United States before returning back to London. Dr. Nicolson is a child psychiatrist whose practice is largely directed to children and adolescents with autism spectrum disorders and intellectual disability. He is a psychiatrist in the Neurodevelopmental Disorders program at Children's Hospital at London Health Sciences Centre and in the Autism Disorders program at the Child and Parent Resource Institute in London. Today, the two of them will be doing a presentation titled Postgraduate Medical Education in Developmental Disabilities. Without further ado, I'm going to invite both of them to the podium, and I believe Dr. Nicolson is going to start the presentation first. So I'm handing over the reins to you, Dr. Nicolson, and please join me in welcoming both of them to the virtual podium with a very robust round of applause. Thank you, Dr. Nicolson and Dr. Dzwonek.
Thank you. Am I unmuted, Kate?
Yes, we can.
Yes, we can.
Okay, good. Yeah. Yeah. All right. Well, thank you for that effusive introduction, Verinder. I appreciate your kind words. It means a lot coming from you, especially. So welcome everybody to another year of CPD rounds. And this year we're going to talk about training in developmental disabilities in psychiatry programs in Canada, or perhaps the lack of training is a more appropriate way to put it. And so sort of the outline for the morning, I just want to talk for a few minutes about the background, why this is an important topic. And then Dr. Dzwonek is going to talk about her experience as a resident at the University of Ottawa. And then I will, Agata will turn it back over to me, and I will talk a bit about some research we've done looking at this question in Canada and what's available and what is not, and what the gaps are really. First of all, I have a few theoretical conflicts of interest, I suppose, but they have absolutely no bearing whatsoever on the topic today. And these are the learning objectives, which are on the flyer, I believe. So prevalence of developmental disability is defined as autism spectrum disorder and or intellectual disability is about 2% in Canada and most countries in the world, really, at least most Canada, United States, but probably other countries as well. And this is sort of one of my many pet peeves and soapboxes, is that there is, even though schizophrenia affects less people in developmental disabilities in the population, there's an infinitely larger amount of time devoted to schizophrenia, bipolar disorder, and things than to developmental disabilities, which, as we'll see, leaves us with a huge inequity in services. So studies have repeatedly shown that people with developmental disabilities have all essentially higher rates of almost every medical problem. And in England in particular, in the United Kingdom, they've done some really great work looking at the sort of lack of appropriate healthcare available to people with developmental problems. So we know that people with developmental disabilities have a higher rate of medical comorbidities and problems. They incur a higher rate of healthcare costs. But beyond that, there is a much higher rate of premature death and an overall shorter life experience. So it's a group of people with an absolutely increased need for medical care. And unfortunately, studies have repeatedly shown they tend to get worse care than the general population. So they tend to get lower rates of diagnoses of conditions, tend to get lower rates of treatment, and even screening things. So I think in the United Kingdom, I think studies have shown that adult females with developmental disabilities and intellectual disabilities get lower rates of breast exams and other sort of cancer-related checks, than the general population. And so we have this real, I say, inequity and disparity, that this group of people with a higher than average need for medical care tend to get a lower than average rate of care, unfortunately. And this applies to psychiatry as well. So studies have repeatedly found that people with intellectual disabilities or autism have higher rates of comorbid psychiatric disorders. And some studies suggest it may be up to 8 times higher than the general population. So I think that whatever we do in psychiatry, for the vast majority of people, we're going to see people with intellectual disabilities. And again, there is this higher rate of the higher rate of psychiatric disorders is associated with higher rates of morbidity, higher rates of service utilization, higher rates of hospitalization, which I think often go very poorly. And Yona Olensky, who's at the University of Toronto, has done a lot of research in this area, sort of outlining what the medical needs are and psychiatric needs of people with developmental problems, and yet the lower rates of access to treatment. And so what studies have suggested is, and there's very little research in this area, but one factor maybe that leads to reduced care is inadequate training of physicians across the board, really. And studies in Canada and the United States have shown that physicians generally, so not just in psychiatry, but again, across the board, feel they haven't received appropriate training in the assessment and treatment of people with developmental disabilities. And this may be due to, first of all, lack of adequate formal training during residency and medical school. And so what I can say, I think, about most medical schools in Canada is there's very little formal, cohesive or coherent or organized teaching about intellectual disabilities. That there's lots of stuff done, actually, no, that's not true. There's some stuff done in developmental pediatrics, some in genetics and things like that, but not in an organized, coherent way so that all people are talking at a similar time, so people get a multifaceted education about it. But so there is a lack of adequate formal training. And then during residency, also a lack of very limited experience with the population. And so, unfortunately, in psychiatry, there's literally a handful of studies at most in Canada and similarly in the United States. And I must say that I think this really contrasts with other countries. So in the United Kingdom, actually, developmental disabilities or learning disabilities, as they're called there, is actually a subspecialty of psychiatry, similar to geriatric psychiatry or child psychiatry here. It's its own subspecialty. And I think it's much more recognized as a significant need. So early studies found, for example, that 1 out of 15 physicians working with adults, working directly with adults with developmental disabilities, reported that they had received appropriate training. In half the residency programs at the time, most of the education was purely readings and lectures, and in part because they were just not clinicians with expertise. And in fact, two programs at the time reported that their residents did not have any formal clinical experience in this area. And one study, which was followed up later on, showed that 72, almost 3/4 of residents felt that the psychiatry of people with developmental disabilities was inadequately taught. So the person who did that last study, Leichner, he went back then about a decade later and re-interviewed senior residents to see how they felt now. So PGY5s, I guess, at the time, but interviewed them with the same survey to see what had changed. And if anything, they noted that there were less opportunities to work with people with developmental disabilities during residency, and that 90% felt their training was inadequate, and 70% felt that so clinical training was inadequate, and also their didactic training. So real limited opportunities, and again, in the context of conditions that occur in about 2% of the population. And so then in 2001, Yona Lensky and Elspeth Bradley surveyed program directors across the country. And what they found was that all the residency programs reported they had mandatory lectures, but it was very limited. And as we'll see later on, I'm not sure who was actually doing those lectures sometimes. And only 7 programs required that residents complete at least one rotation or some time in developmental disabilities. A year later, another survey of senior residents showed that the majority had some training, but the vast majority also felt that it was really inadequate. Given the discomfort that most people have and the lack of experience that people have, they felt that more clinical opportunities were necessary. So the Royal College has, over the years, changed their requirements, as we know, especially with the competency by design model now. But they have typically been remarkably vague about what is required. So prior to the current model, their criteria said that people had to have, and essentially I'm quoting, some experience in developmental disabilities, but it didn't say what that experience was and how long or anything like that. So right now it says there has to be training experience in the, quote, care of special populations, including patients with developmental disabilities, and formal instruction in this area. But again, there is no further description of, so is seeing one patient once, is that a training experience in the care of this population? And what does it mean? And there's absolutely no description by the college about what they require. And what they also say is that by the end of the residency, residents will be expected to recognize and treat psychiatric conditions of people with developmental disabilities, but they don't provide any information about how that's actually supposed to happen. And I think in some programs, certainly the question of even who has the expertise to be leading these areas is concerning. So I will now stop sharing. And where am I here? There we go. And so I will now turn it over to my esteemed colleague, Dr. Dzwonek, who, as we heard, graduated from the University of Ottawa just a few months ago, and to talk about her experiences. So, Agata.
Awesome. Thank you. Can you guys hear me?
Yep.
Perfect.
Yes.
Can you guys see my slides too?
Yes.
Awesome. Great. So yeah, my name is Agata Dzwonek. I'm a clinical fellow right now in the neurodevelopmental disabilities program, of which Dr. Nicolson is the program director. And the purpose of today's presentation on my end is really to kind of show you what my experience has been with neurodevelopmental disorders and how I got to the fellowship today, given what Dr. Nicolson has said about the lack of education in that specific field throughout residency and medical school. So I don't have any disclosures. So to give you a little bit of background about myself, it might explain or help you understand how I got into neurodevelopmental disabilities. When I went into medical school, I was particularly interested in acute care. And when I was in my clerkship years, I had the intention of applying to anesthesiology during the CARMS rotations. And I had set up rotations in anesthesiology, filed my applications and all that sort of stuff. But psychiatry was actually one of the last rotations I had in my 3rd year of medical school. And what's really stood out about that psychiatry rotation was that the type of relationship, the privileged relationship that physicians have with their patients is very unique to psychiatry. And I feel like that's obvious now when I talk about why psychiatry versus anesthesiology, or anesthesiology have virtually no unique relationship like that. But the other thing that I really particularly enjoyed about psychiatry was the dignity with which the patients were treated by both the psychiatrists and the nursing staff. So overall, it was a very positive experience that ultimately led me to modify my CARMS stuff last minute, and I ended up applying for both anesthesiology and psychiatry, interviewed in both specialties, and ultimately I did choose psychiatry for an array of personal and professional reasons. So I did match into the University of Ottawa, and I completed my residency training there. And I dug back through what our actual schedule was for the disabilities training. So at the University of Ottawa during the first week, this is prior to the competency by design curriculum, we had mandatory blocks throughout the first year. And one of those blocks, which was a mandatory block, consisted of 2 weeks of neurodevelopmental disabilities and 2 weeks of neuroradiology. So those 4 weeks together consisted of one block. And quote was passed on from the senior residents regarding this specific block. I do recall there were an array of opinions. One of them was that this was an easy block. The other one that the other kind of rumor that was heard was that this is not a block that is worth wasting your vacation on, so to speak. So block or take vacation during this block because it's kind of like a joke. So there was a lot of kind of prejudice and stigma already kind of set up right off the bat when going into this rotation. And this is kind of what the 2-week exposure looked like. So I blanked out some of the names of physicians involved in this, but this was my block 11 during my residency training program. So as you can see, I had some stuff to do on a morning. I actually don't even know where Monday was in all of this, but Tuesday morning I had something. Afternoon, maybe I had something. Wednesday was academic day. Thursday, only something in the morning. Friday, only something in the morning. And then a Monday again with a clinic in the morning. But overall, very sparse. And unfortunately, I am disappointed with myself in retrospect to admit this, but I did take vacation during this block, as advised by the wise residents preceding me. And I do refer to myself as a blind follower with regards to this, because I perhaps, but I think at the same time I am an example of the reality of what residents kind of experience when they go through these sorts of rotations. For personal context, I had actually changed this rotation and to have it at the end of my first year because I was returning from maternity leave. So I was hoping to, quote unquote, have an easier time after returning back from my first maternity leave. Not that that excuses anything today, but I'm just trying to be frank and honest about the realities of what exists in the residency programs. The additional exposure that is available for neurodevelopmental disabilities in residency would probably be found during the child and adolescent rotation. This is a mandatory 6-month rotation, at least it was prior to the competency by design curriculum. But not all residents in Ottawa had a chance to work with a specific staff or service that was involved in assessment of neurodevelopmental disorders. So I personally didn't have that experience. I do know a couple of my colleagues may have, but generally speaking, I think this probably would have been the extent of the exposure that we had. So I thought about, why are these things happening? Why is it that these senior residents told us their opinion about this block? Why do they have this certain opinion? So again, I wanted to be candid about this, and this is only my personal perspective, and it's not at all reflective of the actual psychiatry program itself in Ottawa. So please take what I say with a handful of salt. But personally, I felt a significant disappointment with psychiatry being a little bit too distant from other medical fields. And I do recall specific interactions with staff or other colleagues where I was surprised that, what seems like a pretty basic thing to be managed was not managed by psychiatry, but referred to other specialties. And again, I understand that there is over time a scope of practice that is established. There are medical legal implications with regards to how we practice, how any specialists practice within their fields. But early in my residency, I recall being told, this particular sentence that I threw on there: why are you wearing a stethoscope? That should have been thrown out when you matched into psychiatry. And the reason I talk to you guys about this is because I experienced, I think, after thinking about it, the word that really came to mind, even throughout my residency, and I spoke about it with some mentors, is this notion of grief. I felt really like I had, by choosing psychiatry, which I really love and I never regretted, I did feel, however, that I sacrificed something very important in my career. And again, this is in the context of me having applied for both anesthesiology and psychiatry. There were things in anesthesiology that I knew I would never be able to reproduce in psychiatry, but certain medical aspects of anesthesiology, specifically around the neurology, the pharmacology, the cardiovascular system, all those things that I just felt like I was really lacking in psychiatry. So I had excellent mentors. I had a fantastic program director at the time, Dr. Talbot at the University of Ottawa, who supported me to explore anything that was of interest to me. And I did have 2 maternity leaves during residency, so I had like 2 extra years of time to think about what I was going to do when I grew up. So the exploring that I did was mostly done outside of my regular clinical duties, and usually often during my academic days. So I was looking for something that could fill that gap that was left behind after CARMS that I was experiencing in psychiatry. Again, how to cope with this grief that I experienced. And I discovered, after talking with other young staff, residents, and that throughout my rotations, I always felt more drawn to the medically complex patients, which usually turned out to be the neurodevelopmental disorders patients. And I did additional work during my academic days with Dr. Walsh-Bergen, who's a community neurodevelopmental psychiatrist in Ottawa. This was during the pandemic, so unfortunately things were limited to virtual care. But we did see people together from group homes, and that's kind of how I spent a couple of years just really confirming and solidifying that, yes, this was actually what I wanted to do, and this did satisfy that itch that I had in the back of my mind, that I could feel very fulfilled. And Dr. Walsh-Bergen did become a very important mentor and a very good friend of mine throughout the residency. So as a PGY3, I was coming back from my 2nd maternity leave. That is when Dr. Walsh-Bergen forwarded me the initial advertisement for the Developmental Disabilities Fellowship in Canada here at Western University. And I think that was the first year that this fellowship had been available. So I did reach out to Dr. Nicolson and Sarah O'Flanagan, who was the administrative assistant at the time, working with Dr. Nicolson to learn more about the fellowship. And what I heard was very interesting. What I heard definitely, again, consolidated that this was going to be the right path for me. So I continued to express my interest, probably a lot. Maybe Dr. Nicolson felt like it was verging on harassment, but ultimately I was successful in securing the fellowship. And I was very grateful to be able to move my family and I to London this past July to start the fellowship. So I wanted to put in a little bit about my personal reflections, like what is it that, why are these stigmas there? Why are these prejudices there? Like, what is it about our psychiatry training? And again, this is only based on personal opinion. This isn't reflective at all of any sort of training, but there certainly is I think a lack of appreciation, globally speaking, from residents about the prevalence of neurodevelopmental disorders in the general population and specifically in the psychiatric population. I think when I was doing my research project during residency, I had come across some statistics that suggested upward of 50% of the outpatient general psychiatry department does have some form of neurodevelopmental disorder. So it's quite pronounced, and I think oftentimes it gets missed. And I think to build on what Dr. Nicolson had said earlier, there is an underdiagnosis of this, but I think there's also an misdiagnosis of a lot of these patients being diagnosed with things that are anything but a neurodevelopmental disorder. I think the stigma of complex patients is not unique to psychiatry. I think this is something that we see in all areas of medicine. But what I truly believe is that if a psychiatry resident or staff can learn to treat individuals with neurodevelopmental disorders, I firmly believe you can treat almost anything with psychiatry. And the reason is in mood disorders and anxiety disorders, in psychotic disorders, we have guidelines. There's evidence-based algorithms that have been put out by Canadian organizations like the CANMAT guidelines. There is no such thing for neurodevelopmental disorders. You basically rely on wisdom passed on from other staff. You rely on clinical experience. You rely on a robust knowledge of psychopharmacology to be able to basically treat off-label, and think out of the box. So that if you are capable of doing that, I think you can pretty much treat anything in psychiatry. And what I really enjoyed about neurodevelopmental disorders is that it fosters curiosity, intellectual stimulation. It involves lifelong learning, creativity, robust knowledge of psychopharmacology, as I mentioned. And I think what is super important is that it's mandatory to collaborate with other fields of medicine like neurology and endocrinology, without which these patients would not be receiving the adequate care. But by collaborating with these additional specialties, that also builds on our personal knowledge, and it increases that sort of perspective of how to diagnose and what to recognize. And I think those are all invaluable lessons that unfortunately, maybe I'm biased in saying this, but I think is very unique to neurodevelopmental disorders. And I think that was it. That's all I had. So if anyone has any questions, I'm happy to take those later on.
Actually, Agata, I just wanted to echo a few things what you said. So the first of all, when you're talking about the lack of guidelines, I think there is very little research in this area, unfortunately. So, for example, with the use of SSRIs for anxiety in children and adolescents with autism, which at times are given out like candy, there's actually no controlled studies in that population, zero, which is, I think, really concerning. And it may be that they're just as effective as in other groups and just as safe, but we don't know that for sure. I think when you were talking about how you were told that there was a good time to take vacation or not to waste vacation, either one of which is insulting. But when I was telling I think Charlene Carson yesterday, when I was in Washington D.C. and I was leaving, and people asking, well, where are you going? And I was saying I'm moving to London. I was going to work with children and adolescents with intellectual disabilities and autism. And I remember somebody, very clearly, somebody who's actually well known in the field of psychiatry, say to me, why would you do that? What can you really do for those people? And it, I think, reflects a real lack of knowledge and understanding, but even experience in the area to ask that kind of question. The other thing, Agata, when you were talking about medications and pharmacology, so what we know again is that this population of people receives less care, less appropriate care. But when they do, well, it's not appropriate, but they often have received massive amounts of medication. There's one young man, I keep his chart in my office, even though I haven't seen him for probably 15 years, just to remind myself, I think he was on, when I saw him, he was about 14, he was on 2 antipsychotics at pretty good doses, in addition to a depot antipsychotic. And he was also taking, I think, valproic acid and a benzodiazepine and a stimulant and an SSRI, and they were talking about adding guanfacine at the time. And it was, I almost wanted to say, you know what, I don't want to see this kid anymore. I don't want my name associated because something bad is going to happen to him. I don't want to be associated with that. Obviously, I didn't say that to his mother, but it was really concerning. And I think we see that a fair bit. In England, in particular, they have a whole movement now, which they, I think it's called STOMP or something like that. I forget if that's the title, but it's around reducing the use of medications, and particularly antipsychotics in this population, because they tend to be overutilized quite a bit, unfortunately. And the other, if I can, and Kate, you're going to have to help me here. So if I also, yesterday, I asked Charlene Carson, who is a PGY5 child psychiatry fellow who has moved to Western this year and is currently working with me. And so I believe, Charlene, and correct me if I'm wrong, you did your undergraduate and your residency at NOSM. And I wondered, I asked Charlene if she could just talk for just a couple of minutes about what her experience was in a totally different educational facility.
Sure, I'll unmute her just one moment. Okay, so you should be able to talk now.
Still says muted on my screen.
Let's see. Yeah, she needs unmuted on her end. I've granted her permission to speak. Charlene, if you're having trouble, can you use the chat?
So I probably picked the perfect time when she had to step away to do something. And I just texted Charlene. So if she's able to get that working, we'll come back to her perhaps. Is that okay, Kate?
Absolutely. Yep.
Yeah, I apologize, Charlene, also if I've called you out at the wrong time. All right, so Agata is no longer sharing. And if I may,
Hello?
oh, there you are.
Oh, hi there. Sorry, I had maintenance just knock on the door.
Yep.
I just,
So Charlene, do you want to quickly introduce yourself?
yeah, so hi everyone. I'm Charlene Carson. I'm a fifth year psychiatry resident now in the Child and Adolescent Fellowship Program here in London. I'm from Thunder Bay, Ontario, so Northern Ontario, where I was doing my psychiatry residency until I started here in London this summer. I think is this where I just wanted to explain maybe some of my interest in this field and maybe comment on what was said in the presentation as well, because I found myself just like nodding along about a very similar experience with craving more exposure and like knowledge for this population, realizing it was even a limitation for my own general residency. And I don't put that towards my specific site. I think I've seen now, even if you're at a big Ottawa program or somewhere in rural areas, while I did see patients with these complex presentations, there was always this, one staff I could kind of turn to, ask for some suggestions, but I felt more limited. And I feel like even just being here working with Rob the last 2 weeks, I'm like, I'm in the right place to learn. And so I think often learning from our colleagues is sort of the one thing we have, because this is such a unique population. And in that sense, we had a conversation yesterday. I realized I'm like, the prevalence of it is so much higher than something like schizophrenia, for example, that I've, become more comfortable, and, there's guidelines that are printed, but even realizing now that this is something that often comes from, it's very unique and, patient focused. That phrase was peppered all over the new mood guidelines. But this is something that I think in developmental disorders has always had to be the case. Just knowing that these patients are very unique, and their families do need support, and often we're that going to be those people at the end of the line that, we're trying to offer support to families. And so I shuddered when this story was shared about, what could you even do for them? And what I've realized, and I really enjoyed the first, bit, seeing some families in follow-up, where I get to hear some of the narrative of, I met this patient when they were 5 and what was happening, and then seeing how things are with families when they're now young adolescents with them and what their quality of life has been, and hearing families like speak to that. I think there's lots that we can do as physicians with our MD hats that can really change like a family's life. So this is definitely an area where I think more eyes need to be on it from psychiatry, and pursuing a fellowship here, very similar. This is the way that I recognized we had to do beyond general psychiatry. So to see it more in our postgrad would be great one day.
So, but Charlene, because you did your undergrad at NOSM also?
Yes, yeah, as well.
So, but in your residency program, what was the availability of educational opportunities in developmental disabilities?
Ooh, there is no specific like rotation. Even she meant, you do like a block or an elective. We did not have that. It's like you get exposure by who happens to come, might coincidentally have one. It's not like a designated stream or clinic, even in Northern Ontario. I know even at our other sites. So what I did see was sometimes there was somebody admitted to the child and adolescent unit on my rotation. And interestingly, it would be oh, like we'll see the other patients because maybe the staff is going to see, you know, young Mikey, blah, blah. And so often I think there was some discomfort with that even as residents. But what I have seen mostly is on our adult psychiatry rotations with our ACT team and through our SPMI rotation and on the inpatient is adults who have lived a life with their family and their developmental disability, and then seeing more than one gentleman admitted to our adult mental health unit because of an issue that happened in community at the group home or placement where they lived, or an elderly parent had died. And knowing that they were essentially living on an adult mental health unit while there was no place for them in the community where they could, quote, safely go or be accepted because of things that happened. And I started to realize, you know, oh, I've done my 6-month rotation and I'm back and I'm like, oh, I can't believe, you know, Johnny's still here. And recognizing that there was no, they were very different. There was nothing, it wasn't like, you know, you're hospitalized because of your manic episode. It was this like waiting game. And then realizing, you know, the support that the nurses had to do, it was a lot of the nurses then getting familiar and getting to know them. And I often, like I did think to myself, like, that's so difficult that eventually you realize this person was once like a young child. And I'm not sure about that longer history, but that's where a lot of my exposure, I think even in residency was just seeing like, oh, those are complex patients, they're medically complicated, it's difficult. This is why they're admitted, but those might be patients we don't round on because they're, you know, alternate level of care and always there. So very minimal.
But you know, and again, to me, for a variety of reasons, that raises concerns, and I don't, but you know, and I can't recall directly off the top of my head what the Royal College says about the required expertise in teaching different topics, but I think that they suggest that these things should all be taught by people with expertise, and it raises a question, and not just at NOSM, I trust me on that, at other schools as well, as who's actually teaching these things, and what does, you know, some clinical experience actually mean? And apparently it doesn't mean a heck of a lot.
Yeah, it was always tough. There was, and the one person who had, for the children, at least they were, with the clinical experience was you know, one of the 2 child psychiatrists in all of Northern Ontario could help with like the younger, children because they had that experience from Toronto, et cetera. But adult wise, I think the expertise, was limited, at least for what we were able to get in terms of like structured academic and lecture. You could have the conversations, of course, with attendings and do some like bedside teaching, but at the end of the day, you were kind of just following, you know, what the standard was for what happens when you're called about, often, you know, a seclusion order into a room. And I felt like really limited in like what I could do as we waited. And fortunately, before I did come for fellowship, I should comment, I did know that that one resident was finally accepted into a group home into the community, but I did realize I was like, it had been almost a year and it was difficult in that sense. So realizing that there was challenges beyond availability in the
And I don't think that's an isolated story, unfortunately.
No.
So thank you, Charlene, for being willing to have me call on you at the last minute and agreeing.
Oh,
I
of course.
appreciate it. But I wonder, Kate, if we can just take a few minutes now for questions or comments if people have them, and then I will carry on with my part.
Absolutely.
Sure, we can. Yeah. So anybody wanting to ask any questions of Dr. Nicholson or Dr. Dzwonek about what has been presented so far, please post them in the Q&A or raise your hand.
Or also, if people have other experiences, I'd really be interested in hearing about that. Because it's obviously something near and dear to me, but it is a huge battle trying to increase, you know, the amount of availability of treatment.
Maybe as we wait for questions to come in, the other point I wanted to make in my presentation that I kind of jumped over and never got back to was this question whether psychiatrists with neurodevelopmental disorders are kind of selling themselves short. Like generally, as we talked to Rob, it doesn't, our field doesn't attract the most eccentric, the most, you know, internal or external gratification seeking individuals. And I think a lot of psychiatrists that I've worked with in Ottawa at least kind of realize maybe that there's this lack of appreciation for what they do. And maybe that's why we also had like half days only for my developmental disorders rotation, because maybe they felt like residents weren't as interested as well. So I think there's a lot of skills that psychiatrists who treat this population should be proud of and should be comfortable advertising, because it's very unique.
Well, again, I think, I guess our purpose is not to sell ourselves here again, but I think that what I appreciate about the job is, first of all, working with families and how much I've learned, but as you said, collaborating. And I think every day I learn something from speech and language pathologists or from neurologists or occupational therapists. And because we have to work so often with other people, but even around, nephrology and gastroenterology, I mean, it's quite remarkable. It's probably the same in other areas, but I don't know if it's the same to the same degree, given that we know that people with developmental disabilities have a much higher rate of medical comorbidity, which makes sense. I think if your brain is developing in a way that is not typical, probably other parts of your body are not developing properly also. Okay, are there any other questions or comments?
In the chat, it says Dr. Lawrence Jerome.
Lawrence is just saying hello to me, actually, Brenda. So
okay, all right. So then nothing else.
So what Lawrence said here, if I may, Lawrence, says, I see a similar lack of clinical experience in adult ADHD, another neurodevelopmental disorder with multiple comorbidities. And I certainly would agree, Lawrence. And where I see that also is in adults with people being diagnosed with autism now as adults, and people often without any clear development. I don't know who's providing that developmental history. And I would think the same with ADHD, adult ADHD. And I've seen some people suggest now, and I don't know what your experience is, Lawrence, but around adult onset ADHD. And I don't know if that's even a real thing. And if it is, I assume it must be very, very different from childhood onset ADHD, because we think of it, as you said, of childhood onset ADHD as being a neurodevelopmental problem. So, and the esteemed Dr. Richard has also commented that there is a similar lack of training among other allied health, like nursing, not just physicians. And, I think, and Julie said, every time an individual with significant intellectual disability is admitted to acute inpatient unit, there is chaos, is the word used. But I will, well, Julie also said that, physician leadership is key here. And I think so. I've said to residents, and I would say it again, that I think in general, I'm not sure that a general hospital psychiatry unit is a good place for people with developmental disabilities. I think because the nature of their, unless they're coming in with what would have been called an Axis 1 DSM disorder, right? Because I think that I think otherwise, if people are admitted for aggression or things like that, I think that it is a totally different skill set for nursing staff and completely different from what they're typically used to. And I think what we see is patients often end up in restraints for extended periods, but also I think that adults who are admitted because their parents can't manage them anymore, they end up staying for extraordinarily long periods of time in the hospital, which, I think that, I'm not saying that they don't need care, don't misinterpret me. I think the system is just not well set up for people with developmental problems who have acute sort of crises in any kind of way, unfortunately. And I think that's a huge concern, and it has been for a long time. Kate, did you want to say something?
Yeah, sorry. I'm just going to unmute Dr. Ross. I think he has a question.
Hi, Rob.
So Agata, just so you're aware, Dr. Ross is one of the residency program directors.
Thanks for this great presentation, Rob.
Yeah, thanks, James.
So I'm just wondering, like, if you could add or modify the current offerings we have in our program, what sort of things would you ideally want to have available to our residents in our program?
Sure. So if I could just back up a little bit with that, James. So because the Royal College doesn't require, has no specific requirements, or they don't define what they mean by requirements, it's sort of it's up in the air. But for reasons I'm not entirely clear on, Western has always had a strong commitment to people with developmental disabilities. I think for a variety of reasons that there are I think very few inpatient units, for example, specifically for people with developmental disabilities. There's one at Parkwood, but I think there are very, very few others across the province.
Mhm.
And I think what we have at Western, so what is there, I think Rao and I have done a letter for residents
Mhm.
on developmental disabilities. I think Loba does as well. And during PGY 3 year largely, or 2 and 3, I guess. But beyond that, what we have required is people spend at least 2 weeks in developmental disabilities, typically during psychiatry rotations. But really, that it's spitting in the ocean, right? I mean, it's a tiny amount of time. And I think it becomes the real difficulty is how do we fit that into the rest of the curriculum, given the constraints of what's required by the Royal College. I think what would be great. So first of all, I suspect that people with milder intellectual disabilities may not always be recognized as having an intellectual disability, but I think that ultimately the short answer is more residents, so that then when they are consultants or specialists, that they would have, even if they're not working consistently with people with developmental disabilities, they would have that experience anyway of being able to help and understanding what some of the issues. I think that I would love to see your question is more time, but I realize that there's a lot of other competing interests as well.
Ironically, our 2-week block during is probably near the front of the pack across the country in terms of what we offer. But as you say, it's just sort of scratching the surface in terms of being able to understand and work with.
Yeah, and I think I think what's really more specialized in this area, as Agata was saying, was people who are perhaps more severely disabled intellectually. I think that people with milder intellectual disabilities who have depression, I think there may be some other issues, but they're not necessarily different. I think it's sort of the more intellectual disability is the more difficult, because particularly in nonverbal patients and things like that, who are probably the people who get missed a lot in terms of psychiatric diagnoses. But it's, and I think more experience, but yeah, I guess the question I would put back to you, James, and I appreciate your question, is, where would we find time? I wonder if what's actually needed is more specific requirements for the Royal College.
Yeah, and that's always, because that's what dictates how we allot our training time. And I think the challenge too is, as I think you were both sort of alluding to, is not only the identified cases, but then in the general population, sometimes there's people who have developmental disabilities as a comorbidity, and how do we kind of harness that as part of training so that people are actually giving effective treatment to these folks within the context.
Well, you're right, and I think that it's, we know that aggression is a common problem, particularly the lower you go in cognitive ability, but as human beings, we act for a reason. I think understanding why that aggression is increasing or things is the important part. And it's difficult. I can understand why people with intellectual disabilities have lower rates of psychiatric diagnoses, especially people with more significant cognitive impairments, because they may not be able to describe their internal world. So asking people how they feel in terms of depression, or somebody with a significant disability who lives with their parents, diagnosing may not always be easy, right? Because they're not going to have access to money to spend recklessly. They may not have the same opportunities for inappropriate sexual relationships. They may not be, if they're nonverbal, determining grandiosity and things becomes really, really difficult. And that's where I think it's the clinical experience, frankly, is more important than the didactic stuff in my mind by far.
If I could chime in as well, I think there's also an opportunity to modify the existing rotations that are there. So for instance, neurology, like I don't see the value of doing a full block of acute inpatient neurology on the neurology acute, like the equivalent of the ICU, it's certainly valuable, but I think there are opportunities within the neurology rotation, for instance, to do like a mandatory epilepsy clinic with some experts and kind of coming across individuals that way. So I think there within the rotations that are presently there might be opportunities to kind of see these individuals and gain experience that way as well.
I think it's a good point, if I may, James, but I think, and this is not an issue only in psychiatry, right? The avoidance of developmental disabilities. So excuse me, in pediatrics, and I'm not sure at all what the requirements are, but in the past, so maybe going back 10 years or so, that every pediatric resident in London had to spend some time at CPRI, but doing developmental things. But a number of them would spend their month or whatever it was on a unit called Pratten 1, which is a treatment unit for people who were technologically or technology dependent, or required multiple cares, were really profoundly physically disabled as well as cognitively. And I think for the average pediatrician, it's not going to have a lot of transferable skills to general pediatrics or to community pediatrics. And I think people did that in part because they're uncomfortable with psychiatry or whatever. And so it's not just in psychiatry that we see these sort of avoidance. I think it's across the board would be my guess.
Yeah. Yeah, sadly. Yeah. Thanks.
All right. Thank you, James. I really appreciate your comments. Okay. So Charlene, did you want to say one thing?
Yeah, just a comment about what requirements like our programs have of us now as somebody going through competency by design. I was sharing with a co-resident colleague after the end of my day, even just yesterday, right? And I'm very early in my rotation, but recognizing it's a different skill set to even redo, figuring out how do you do an AIMS assessment or try to assess like cranial nerves in someone who can't stop pacing the room like aimlessly and doesn't have those same like type of skills where you can just give direction, touch my finger, nose. And I think even just doing small things like that and making it like something I had never even thought about things like that. But if it was like structured through our residency, and just realizing what you have to be able to catch. And I think psychiatry, we're very well suited in a way to support even our pediatrician teams in the community, because I think at a certain point, yes, they're doing those rotations, but for us with that experience and that with medications from, our past experience in general psychiatry with adults saying, okay, I think this is what's happening with this medication. I think those opportunities, like just having that patient time where you can work with someone and be able to spend time with patients can be quite helpful. But it is something that we just don't see quite as much every day. You're mentioning Dr. Dzwonek, the neurology. I remember my first year neurology rotation, lots of really good, experience, but thinking to myself, where are the patients going, that do have more severe like neurological issues and that, and those might be the patients where if we were meeting them instead of an acute neurology service, it may be quite helpful.
Or, I mean, I think the other thing, so Dr. Miriam Nouri, who's a neurologist over at Children's Hospital, what she has developed is, is a multidisciplinary clinic. And, and certainly it's not rocket science, but yet it didn't exist. And the one she developed specifically is for people with tuberous sclerosis who often need to see multiple physicians. And so one patient I can think of, the family lives in Windsor. And because tuberous sclerosis can affect most of I don't know if all organs, but most of them, this young man had to he was seeing a nephrologist, a cardiologist, a gastroenterologist, a neurologist, and a psychiatrist, and was never coordinated in any kind of way. So family was literally coming from Windsor to London every couple of weeks to see somebody. And so what Miriam did, and it's not large yet, but I think it's a great model, is having sort of one day every few months where people perhaps the more difficult to manage or treat patients would come in and see everybody on the same day in the same clinic. And so that way people have the opportunity to discuss with each other what's going on and how we're going to approach things. But also it makes it so much easier. If we talk about patient-centered care, that's the definition of it, I think. I think that's the kind of thing that also fosters communication and expertise and comfort. James, did you have another comment?
Oh, sorry, I meant to put my hand down. I think I put it up again.
Well, now that it's up, you have to make a comment, I think.
Sorry?
No, I'm kidding. So I'm going to move around. We have time later on for questions as well. But I will now share my screen here. And Kate, can you just tell me what view you have there now?
It's just a black screen. Oh, there it goes. I see your slides now.
Okay, but just the slide, not the other part?
Just the slides.
Okay, so I want to talk a bit about sort of more recent research that we've done looking into this. So 3 or 4 years ago, I can't remember exactly when, Sarah Flanagan and I had sort of embarked on this idea of looking at trying to understand the availability of postgraduate Education and Developmental Disabilities in Canada. And so we sent surveys to every program director in Canada, and some were great at responding, and some needed a bit of encouragement. And basically, our questions were pretty straightforward. You know, it's sort of what kind of what didactic teaching is there in developmental disabilities, what required rotations are there, and what elective opportunities are there for people to see people with developmental disabilities. And eventually we, so, you know, it says here there were 19 questions, but they were sort of subparts of the main questions. And eventually we received responses from everybody, which was great. But what we found was there was a huge variation across the country in terms of availability of teaching and the amount of that teaching as well. So first of all, every program required some didactic teaching. I'm not sure, I mean, the 10 hours seems like a large amount to me, and I'm not sure what that would entirely consist of. But certainly there was some didactic teaching. I don't know who was doing it at each center, but it was available, which is a start. I think, unfortunately, a lot of stuff around developmental disabilities now is specific to autism for a variety of reasons, and may not necessarily cover the larger range of people with developmental disabilities. And, you know, most of the teaching as it is here in Western was in a sort of PGY 2 and 3 years. I'm not sure what formal didactic teaching would occur in year 5 or why at that point, to be honest with you. But, you know, the questions that we had, and we sort of for future issues, you know, who is it who's actually doing the lectures? What's their expertise? And more sort of what are the broad topics that are covered? And certainly in brief answers to these sort of more qualitatively, there was a wide variation across the country. But, you know, I think the more problematic concern for me is that only 6 programs required residents to complete a rotation in developmental disabilities. And again, that varied widely. I think might have been Queens, I'm not sure. I think requires 1 month in developmental disabilities. And here at Western, we have 2 weeks. But obviously then 2/3 of, or almost 2/3 of programs did not have any required rotation at all in developmental disabilities. So people just were seen as residents saw patients with developmental disabilities as they went, without, not in an organized fashion, and not necessarily with a consultant with more expertise in the area. And I think without experience, it becomes just even developing comfort with this population is really, really difficult. And a few places, so I think, and we'll come back to it in a moment, but we also looked at what residents thought about training in this area. But for a number of places, it would be, you know, 1 day in a center for people with developmental disabilities, just observing things. So really, it may qualify as a rotation, but doesn't really count as experience in my mind for people. And when we looked at sort of elective rotations available, you know, 13 schools offered an elective rotation, but 4 did not. And ultimately, when we looked at what was required rotations and clinical and electives, there were 2 schools. I don't remember off the top of my head who, and even if I did, obviously I wouldn't say, but the who did not require any rotations in developmental disabilities and did not offer any elective rotations. So they had no formal requirements for seeing patients with developmental disabilities, which is, again, and just the amount of time devoted to schizophrenia and bipolar disorder, both of which occur at a lower rate than developmental disabilities, concerning to me that this population, which we know has a lack of appropriate treatment, is again getting, frankly, not the same level of care as other groups. And so again, we have the question, you know, it's presumably then for most schools, people supervising would be other consultants, which obviously that's great to have those people, but particularly in patients with more significant intellectual disabilities, I think that's going to become problematic. And I think, and James, if I'm wrong, please correct me, I think that the college still says there has to be people with expertise in this area at each center. And I wonder how they actually determine that, and even how they define expertise, frankly. And so I will come back to this. Well, so with this, you know, that there were not a lot of opportunities, that there were far less schools that should have offered opportunities. And, you know, that the bottom point, I think, is the most worrying thing to me in a lot of ways, or maybe not the most, but is that compared to 2001, there are less schools offering requiring rotation specific to developmental disabilities than there were. There are less now than there were in 2001. Now, Royal College requirements have changed since 2001, so that may be a contributing factor. But given that institutions have closed and there are more and more people with intellectual disabilities in the community and they're living longer and longer, and the fact there are fewer requirements is hard to explain, really. Okay, so field limitation study, obviously, you know, there was a small number, but frankly, it was also 100% of residency programs in Canada, and similar studies in the United States have found very similar results. And what we got was the program director's perspective, or what was required. So it's not necessarily what people are going to experience, because as Agata said, of people taking vacations or other things, and so people may not experience what is available necessarily. All right, so I'm going to stop sharing it here for a moment. And I just want to go over talk about a different study we've done, which just got the results, well, more formally recently. So the second thing that we did was we wanted, okay, so we have what program directors say is required. What do residents report though, and what do they recall? And being in London, we were in a good position to be able to look at this because of the annual exam preparation course. And so for 3 years, I believe, we had, as part of the package of people attending the 5th-year residents attending the exam course, preparation course, were given questionnaires to fill out around this area. And one of the things I learned about the survey research is that without some incentive, nobody's going to respond. And so the first year we did it, out of several hundred attendees, I think maybe 40 people turned in their questionnaires. So what we learned the second year was that we offered people a small gift card to Starbucks, really, for $10. So even fairly a small amount, but it actually increased the number of responses we got pretty dramatically. And so in total, over 3 years, we received 305 responses to the questionnaires. Now, 47 of those were from people who either hadn't done their residency in Canada or were not, I think some people were in their PGY 4-year for some reason. So not necessarily people who were in their PGY 5-year from Canadian programs. And so what we ended up with 258 people who were 5th-year residents from Canada and who had and completed the surveys. Off the top of my head, I don't remember what the denominator was, how many people attended in those years. I'll have to look that up. But anyway, so what they responded was that, so 243 out of the 258, so a significant number, reported that there was didactic teaching in developmental disabilities at their university. But at times, it's the comments in some ways are much more interesting. So what people responded, things like, one comment, I don't remember any formal teaching if it in fact even happened. Somebody else said, I had one lecture as a junior resident. A third comment was, it was given by an excellent psychologist, which is great, but, and I don't want to disparage our psychology, but in terms of the actual medical issues, may not be adequate or enough. And then other people comment, very little, maybe 1 or 2 hour lectures early in residency, 1 lecture if I recall. So really comments across the board that yes, that most people had some, but really couldn't recall very much of what was covered, and there really wasn't very much either. So the next question we asked then was, were there any required rotations? And what we found is out of the 258 respondents, only 104 said yes, they had required rotations. Now, keep in mind that this is people in their second half of their 5th year of residency. And so if they had done something for a week in 2nd year, it's possible people may longer recall. But it's, again, less than 50% had a required experience. And again, the comments were things like, we had to do 2 half days at an intellectual disability clinic, mostly as just observing. Or we saw a few cases of autism in child psychiatry. At my university, we had to do 3 days of observation. And then, even more concerning, so they all say, no, we had no required experiences, but I did have experience on call, and inpatient. And so a lot of comments about not being specific to developmental disabilities and not really having a lot of experience in it. Let me see, not offered in our program routinely was another comment. And again, what people do say also, a comment was that some of the required rotations were in child psychiatry and often in autism-specific clinics. So not necessarily with people with with intellectual disabilities or more severe intellectual disabilities. The other concern for me in this area is that there are not enough psychiatrists with experience in child psychiatry with developmental disabilities, but there are also people in neurology and developmental pediatrics who can cover if needed. Really, where the real shortage is in adults with intellectual disabilities, and there is a very small number of people with expertise across the country. And as a group, we tend to be getting older. And I remember probably 15 years ago talking with Peter Zatmari, who was in Hamilton and recently was the head of child psychiatry in Toronto. And we were actually talking about how many residents are there who go into developmental stuff full time once they finish their residency, and it is a tiny number. I think he described it as an asymptote approaching zero. And it's a very small number of people. Unfortunately, it's not increasing at this point. So the other thing we asked was, how long were the rotations that were required when they did have required rotations? And again, it ranged from 1 day to, as say, 1 month. So very short. Which is not adequate. Sorry, just and then the next question we asked people, were electives available? And so a majority of people said yes, was 221, but it often was what people said, it was difficult to find people, and so one comment was they're available, but they're extremely difficult to access. Took the opportunity to do electives. Somebody else had commented, I did have to commute. I don't know what that's relevant to, but I even requested a psychiatrist get a faculty appointment to complete an elective. So they just didn't have the same opportunities. It just started echoing. Can you hear that, Kate?
I did. I got it.
Oh, okay, thank you. And so just, again, just people coming, just wasn't available. But the final, question that we asked of people was how, given that you're in your last year of training, to assess and treat people with intellectual disabilities and developmental disabilities. And so the first question, what is your level of comfort in assessing psychiatric disorders in people with developmental disorders and intellectual disabilities? And out of 258 people, 29 people said they felt comfortable. And 50 people said they did not feel comfortable in any way, shape, or form in assessing psychiatric disorders in people with intellectual disabilities, which is obviously concerning given the prevalence. But then the next question was, and how comfortable are you in treating psychiatric disorders in people with intellectual disabilities? And 24 out of 258 said they felt comfortable doing that. So a huge dearth of comfort as well in this area, not only experience, but also comfort. And it just sort of perpetuates this sort of lack of services because it means there's not enough people getting appropriate, well, firstly to treat people, but also then to educate the next generation of psychiatrists. And if I can, I just want to read a few of the comments from this section. So we received minimal training at my residency program. The only clinical experience we ever had was with individuals with intellectual disabilities was in the emergency department during a crisis placement. And as I say, I noticed that while on call, if an adult patient showed up and had to be assessed, not knowing or not identifying intellectual disability made the assessment very challenging. It was a topic I was eager to learn about, but didn't have the opportunities. More training is needed. I'm clearly less comfortable than treating other psychiatric diagnoses. And, the one comment that really hit home for me when talking about training experience and things in this area was one of the comments was that the only educational experience they'd had was the 2-hour case presentation and lecture that I do as part of the exam preparation course. So this person reported their only experience was what was part of the exam preparation course. I mean, I don't think that's probably necessarily the norm, but it is certainly concerning and worrying in terms of what people are getting exposed to. So if I may, I'm just going to share my slide just to, again, for one moment here. Where are we? There it is. And Kate, that is visible?
Yeah, it's visible.
Okay, great, thank you. So just to wrap up, that all physicians, particularly psychiatrists, perhaps will definitely see people with developmental disabilities in their practice. May not be recognized always, but will be seen for sure. And that the opportunities in this area are limited, perhaps because the Royal College doesn't require it. I also wonder if the Royal College doesn't require more because they know that there's not the expertise available. And additionally, despite the fact that institutions have now closed in Ontario and probably across the country, and there are more people with developmental disabilities in the community, there is not necessarily any more education available to residents than there was in the past, even going back to the 1970s. And that really there is a grossly insufficient amount of time devoted to this population and available for residents, which is something that we are trying to address. So if I could just say the one other thing that we've done, in addition to what James mentioned about having a requirement of at least 2 weeks, and I must say many residents spend more time than that with either myself or somebody else in child psychiatry, and also we have residents working with the group at Parkwood. And through the generosity of the Ministry of Children, Community and Social Services, we now have a fellowship in this area. And so Agata is the second person doing that. The first was Ashley Galloway. And providing an extra year of training in this area, so more expertise, with the goal being then that people will then be able to either stay in London or go back to their own community with that expertise, both to train other residents and future residents, but also to help for treatment and assessment of patients today. And so that is all I'd say. I would like to thank Agata and Charlene. And I must say, Agata, one of the things I recognize about you is that you often see neurodevelopmental disorders when nobody else does. How is that for a change on what you might have been told by others? But I appreciate everybody's participation, and we have lots and lots of time for discussion now if people have other comments.
Thank you, Dr. Nicholson.
Yep.
So we have in the Q&A a question from Dr. Jerome, who says, is there anybody working on developing guidelines for this population?
So, Lawrence, that's a really interesting question. I think part of the problem has been that the group is, I don't want to say fragmented, but there hasn't always been a organized, cohesive way for the group to get together on a regular basis. People across the country, that there is a section within the Canadian Psychiatric Association, but bizarrely, at one point we had, and full disclosure, I wasn't a member of the Canadian Psychiatric Association at the time, but we had tried to get a list of the people who were members of the Canadian Psychiatric Association group on developmental disabilities, and the association wouldn't give us that list unless somebody was a member of the Canadian Psychiatric Association, even though we wanted it for educational purposes and to understand how we could arrange more things. And CPA meeting, there is I think the attendance varies wildly from year to year, and so aren't anything. So I've actually heard people talk about working towards making it a subspecialty in Canada. I just don't know who has the energy or the drive to do that. I think if I'm especially 15 years or something like that, and so to do it developmental just as long, and there's the same critical mass of people who would be able to push that forward. There are some guidelines. So the American Academy of Child and Adolescent Psychiatry guidelines for the assessment and treatment of intellectual disabilities, but they are fairly vague because obviously there'll be a whole range of factors to consider, and that is only children and adolescents, it's not adults. To the best of my knowledge, there's no adult guidelines at all. I mean, do you know of any, Agata?
No, I don't think there are any formal ones, at least not Canadian, but there is so Dr. Walsh-Bergen did try, and she has started a group of people across Canada, kind of informally on the side, with the intention of raising some awareness, planning the medical education piece as well. So it is interested in participating in that. The meetings so far have only been, you know, like once every few months, but that is there, that exists. And I think it was a spin-off of the Canadian Psychiatric Association. It was to bypass what you said.
And I think it's the Ontario Medical Association also has developed a working group on developmental disabilities with people not just in psychiatry, but also developmental pediatrics and neurology and things like that. But I'm not sure where it's going. So I think there's people with ideas. The sheer amount of work that would be required.
Thank you, Dr. Nicolson. And anybody else in the audience has any questions, please raise your hand or post your questions in the Q&A that you can post in the chat. We'll really appreciate it.
You know, if I can, while we're waiting, Brenda, the other area that, and I've been meaning to talk more with people in geriatrics, frankly, is about people with developmental disabilities as they age. Because the population, obviously, people are living longer and longer and longer. I was telling Charlene yesterday, I have a person who's on a number of committees with me in this area. And this woman, I'm assuming she's in her early 90s, but she has a daughter with Down syndrome who is, I think, in her early 60s, if I'm not mistaken. And, you know, one generation ago, there is no chance that her daughter would have lived till that age. And so I think that as people get older and older, maybe one of the geriatrists can chime in. Well, I'm certain that there's no required opportunities in this area, but how often are people in geriatrics seeing people with developmental disabilities now, particularly, I guess, autism, but also intellectual disabilities as they age?
We are seeing them in the ACT teams, so definitely the geriatric population is also seeing them.
So, Brenda, this is a silly question, and maybe I should have asked it 20 years ago, but HACT is assertive community treatment?
Yes.
But do you guys do geriatrics also?
Yeah, so we actually ACT looks after patients as long as they don't have a diagnosis of dementia. It doesn't matter what age you are. We have patients who are into their 70s and 80s that we are looking after.
How often do you think you see people with intellectual disabilities? I would assume that number is going to be increasing as time goes on, just because of lifespan.
Well, definitely the intellectual disabilities number is increasing. We are seeing increasingly larger number of patients because if you think about the developmental disabilities program that we have at Parkwood, the level of support available in the community. So sometimes those patients get referred to us. We try to do a collaborative work with the developmental disabilities program, but invariably the burden of the work falls on ACT team.
You know, and when we think about geriatrics, the other issue, and I remember I talked with Sandra Fisman in the past about this, is that we know, I don't know if it's actually 100% completely, but the vast majority of people with Down syndrome, if they live long enough, will develop Alzheimer's disease, and typically at a much younger age. And so I'm not sure who is seen as being responsible for them. If somebody at the age of 50 has, you know, Alzheimer's disease and they have Down syndrome, are they, you know, I realize that geriatrics may not be about age, but I think still 50 is very young to think of somebody as needing to see a geriatric psychiatrist, but they would also be people with experience with Alzheimer's disease.
Yeah, so they would be seen by geriatric psychiatry. So if you have dementia at a younger age, those patients.
So it's not age limited.
Well, yes, it's more diagnosis driven, but I'll let maybe if there's any geriatric psychiatrists in the audience also answer that question. If not, we do have a Q&A from Dr. Serena Ho. She has a comment. I have also noticed that there are more people with developmental disabilities in nursing homes who are being referred to psychiatry because staff are also not prepared to provide that kind of care.
Yeah, and certainly that's what's reported. It's not my experience, given I'm a child psychiatrist, but and I think this is where in England as well, there's this real movement to reduce the rate of psychiatric medication used in people with developmental disabilities, particularly antipsychotics, because we know that the rate of let's say aggressive behavior is higher in the developmental population, and so given that nursing homes don't have enough nurses, and they're run off their feet a lot of the time, that anybody who's going to be really disruptive, I assume, unfortunately, is often given medication that there may be other ways of dealing with that behaviorally, but there's just not the manpower, or sorry, the person power to do that. And it is, and I think that's where there's, that inappropriate, I don't want to say inappropriate, but more problematic medication use, let's say.
So polypharmacy in and of itself is a huge problem in nursing homes.
Yep.
But I would even say, before we start pointing finger at nursing homes, it's a problem in our own hospitals.
Yep.
It's on adult wards. I can't speak about the child and adolescent wards, but definitely on the adult and geriatric wards, it's a huge problem. People keep on adding more and more meds.
Yep.
And not taking the time to actually reflect on why are we adding this medication, and what do we need to do to reduce or actually take away some of the other medications, which perhaps may not even be working, and we are increasing the side effect and intolerability burden for our patients.
Oh, and again, we know from lots of research, people with developmental disabilities have higher rates of adverse effects with medications.
Yeah.
But they also may not be picked up, especially if people are nonverbal. But what I see in younger people, Verinder, is particularly again around aggression and things, that if people have been really aggressive or really self-injurious, as they've gotten older, if things have improved, their parents understandably become really reluctant to do anything, despite the fact they may already be taking a number of medicines, and they're terrified. And again, I can understand that about changing anything because of things potentially going backwards. And what I will sometimes say to parents is, I agree completely, but at the same time, I would hate to see your son or daughter 40 years from now with no problems in the interim, but still taking the exact same medication.
Mm-hmm.
And I think that people are sometimes, as you say, don't take medicine away because they're worried that if they take it away, things are going to get worse. But if somebody is hitting themselves constantly or so aggressive, they're in restraints a lot of the time, I'm not sure how much worse it can be, really. I don't want to find out either. But I think that is a huge issue with the polypharmacy. And I must say, certainly I have some patients of my own who I'm frankly embarrassed when I look at their sort of medication regimes. And I can sort of explain how we got to that point, but it still looks really unattractive, particularly in people who are already cognitively impaired and have more side effects of medicines and stuff like that. And it is, especially because, we don't have medicine specifically for people with developmental disabilities. And so we don't know whether things work or not. And certainly that's the boy I mentioned earlier who was taking, a zillion different medicines. I think what had happened was people, again, just kept adding instead of saying, what, let's take things away. And I think it was William Osler or something like that who said, the more medicines that a person's taking, the less likely it is that any of them are actually doing anything useful. And I have no issue personally with polypharmacy if they are for different reasons, right? So if somebody is aggressive and has significant anxiety or something like that, makes sense, they might require 2 medicines. It's when somebody's taking 4 medicines for the exact same problem that it's really concerning, I think.
I agree 100%. But at the same time, also, I do want to say that sometimes you have to end up using polypharmacy because lower doses of 2 different medications perhaps is better than using high dose of one where they have more adverse impact.
Yeah,
so I think
sometimes you have to, sorry.
Yeah.
Sometimes you have to do what you have to do, right? Especially in acute situations. But because, again, the developmental sector is not equipped to deal with acute situations. And so sometimes things are required urgently. So we saw a young man yesterday, Charlie and I did, who has a fairly rare genetic condition and is really hyperactive and really aggressive at times. And it's really difficult for his family to manage. And it has, has had an impact on everybody's quality of life and has been on a number of medicines with limited to no success. So I had started him on methotrimeprazine, and so we saw him yesterday, and he looked drunk, frankly. He was literally almost staggering And his mom was saying, you know, certainly his behavior was much easier to manage, but at the same time, he's not himself. He wasn't doing well at all. And that's the kind of thing we don't want to see, is, you know, sacrificing people's personality and their quality of life just for their behavioral issues. It'd be nice to be able to strike a balance between those two. I wonder if any of the inpatient psychiatrists, either child or adult, want to talk a little bit about their experience with people with developmental disabilities on the inpatient unit. That, as I say, my belief personally is that people with developmental disabilities probably shouldn't be admitted to acute care general hospital psychiatry units unless there's a clear mental health problem. But I don't do inpatient things, so it's easy for me to say that. I wonder if anybody had any opinions about that.
I don't see anybody raising their hand. Kate, anybody raising their hand?
Not
So
yet. No.
There's a comment here from
So there's a comment from Dr. Michael Warren.
Yep.
Thanks for the great talk. There seems to also be the gap of transition of care for patients with developmental disorders from child and adolescent to adult services. It seems that it might be a lack of experience from some of the adult psychiatrists to take on these patients, as well as a lack of robust multidisciplinary teams to help support these patients on the adult side. Lots of these patients end up being admitted to acute care facilities when they are adults. Any thoughts on transitioning to adult care for patients with neurodevelopmental disorders?
Yeah, I mean, Michael, that's an excellent point. So just here in London, for example, so in a lot of places there's limited availability, and you know, with child and adolescent psychiatry, theoretically we see people till they turn 18 and then they move on, whereas adult psychiatrists see people till they die potentially, and so for a much longer period of time. And so obviously there's less and less time available for any one psychiatrist because they potentially going to have a much larger practice because they see people over such a wide age range, and you know, this, you know, it seems to me that everybody talks about breaking down silos, but nobody really wants to get rid of those. And so at Parkwood, there is what I have been told, and I don't know if it's the official position, is that they will not accept referrals to the dual diagnosis program until the day people turn 18. But they have a fairly lengthy waiting list because of the demand for services. But at CPRI, for example, we are supposed to stop seeing people when they turn 18. So there's a built-in gap potentially of care because of that, you know, the waiting list at Parkwood and the need to discharge people at CPRI. I think for some people that we see, they can certainly be managed by their family doctors, but a lot, particularly with more severe problems, can't. And so that's automatically a built-in gap with that transition. And it is what I have a really hard time with, Michael, is people who have intellectual disabilities and sort of milder mental health problems who need following up. But I think because of the demand for services in the dual diagnosis program, I'm reluctant to refer people with milder problems because there's such a huge waiting list anyway. And so that's where it becomes very difficult also to find anybody who will see people. And that's in London. So I have patients obviously in Kitchener, Waterloo, and things like that. And I don't know what to do with those patients sometimes, to be honest with you. I have to almost ask parents, you know, can you find out who would be the best person for your child to see when they turn 18? The other issue that goes with that obviously is the lack of family doctor for people. And not having that continuity of care. I guess, Michael, if the system
that started, but and maybe Ian, you're probably more familiar with it, so maybe if you want to talk about that. That's an attempt to again educate, you know, and I even suggested that he should not only just limit it to family physicians, but also psychiatrists who work, you know, like myself, who work with adults with intellectual disabilities.
Yeah, absolutely. And my experience is even, you know, neurologists and geneticists have a pretty complicated, they're going to see these patients. And and Jay, this is something that's been near and dear to Jay's heart for a number of years, I think. And again, finding the availability of stuff. And he's developed modules on this. And he and I had actually done some stuff for teachers in the past. But okay, so at CPRI, we did something similar with pediatricians and family doctors for children and adolescents with developmental problems. And I suspect that the problem across continuing professional education is that often I think we end up preaching to the choir, right? So people who are already interested who know things, and people who attend those, people who perhaps would benefit from more knowledge or understanding don't. And so it's how do you reach the unreachable in a way, I think is the question. And certainly we have done that, and I think it worked quite well. We had sort of a 6-session thing, and we didn't do it last year, but previously we had done it for 4 or 5 years. And once a month in the evenings, we provided dinner to people, and even still, attendance was spotty at best. But I know this is something Jay has talked about for a while. And if he's able to get it going, that'd be great.
Yeah, thank you. And back to Dr. Nicholson's request to the audience members, any child and adolescent psychiatrists who want to talk about their experience of dealing with patients with intellectual disabilities. And
So
maybe I'll let you take over.
So Kate, Michael has his hand raised and just needs to be unmuted.
Okay, I will unmute him now.
Yep.
Oh, thanks, Kate, for doing that. Yeah, no, it's an interesting question. I think I've had the pleasure of working with both Dr. Nicolson and then right now Dr. Richard, and I've seen kind of that gap between those two services where it feels like these patients that may not have this very complex needs of a dual diagnosis program through Parkwood, but still have a comorbid neurodevelopmental disorder with some underlying mental health concern. And then we also know that transitional age youth kind of age range is a higher risk for those mental health disorders too, right? So it seems like there's a big gap. And I know Dr. Richard takes on a lot of patients, and working in her clinic, it's been a blast because it's been a lot of kind of that dual diagnosis piece, right? I think from the patients that you've had and meeting with them. But I think for a lot of patients, it seems like they're kind of just discharged to this, unknown service, right? We don't have really robust services for people as soon as they turn 18. They're kind of left to the wild, I think, especially with a lot of families. And I've come across quite a few patients that have been admitted recently, and usually in early 20s or late 20s. And the family has just been pulling at everything just to have, some semblance of normal at home. But the kids or the adults are now just having such high demand of needs. And now they're coming in acute crisis and they're admitted to an acute care facility where really we don't have the resources for them. And then they end up sitting for a long time. And it doesn't seem like a great discharge plan because I think a lot of psychiatrists are hesitant. I think the clinics require a bit more support. I think you need not just the psychiatrist, you need that multidisciplinary support.
Yep.
So I don't know what the answer is. It's almost like a bridging program between the two. I think especially for complex patients. I know it's a lot of strain put on the dual diagnosis program because to your earlier point, 18 to 70, 75 is a long time to be carrying patients, right? So I don't know, how do we support general adult psychiatrists to be able to take on some of those patients with more complex needs?
That's actually a great question, because I think if there was some kind of almost consultation kind of, so not necessarily with patients, but if there was, so a few years ago, I'd met periodically with a group of pediatricians, and we would just talk about, they would just bring cases and we'd just talk about them. And I wonder if that's the way to do it. I think then the issue becomes funding and things like that. But it is, there really isn't that availability. And family doctors, from the experience, I think there is no reason that we couldn't have that, though, because in other areas, there is a much more robust, let's say, transition plan. So I think for people with cerebral palsy and people with epilepsy, I think there's a fairly well-developed transition program from child to adult services, which doesn't exist in developmental psychiatry. I'll have to think about why not and what we can do about that. I think part of it is the lack of availability and the lack of and the lengthy waiting list. But I think, Michael, the other issue in general, so obviously is that as parents get older and older, and the government's not building any group homes, then things become even more of a problem when parents aren't able to manage their kids anymore, or they're just too old or don't have the energy. But I think our system also, and perhaps I see it more with autism, is just terrible. That negotiating the Ontario Autism Program is not easy, and I say to not infrequently that if you are reasonably well educated and English is your first language, it's still difficult to negotiate that system because there's so many different players sometimes. For people who don't speak English as a first language, or if parents have any kind of learning issue themselves, I don't know how people do it sometimes. And it is terrible. And the same with intellectual disabilities, that I think that there are sometimes more services than people realize. But if you don't know who to ask, and if you don't know what to ask for, you're not going to get it. And it's more of a systemic problem, almost certainly. And it's, but I think that's something to think about, Michael, is, why we don't have something more organized. I know that Agit 9 and at CPRI has met with people at Parkwood to talk about that. Is there any way to facilitate that sort of transition for people who need adult services? I'm not sure what more has happened with that at this point in time, though. I mean, I got it. In Ottawa, what do they do from child to adult?
So there is a big gap. There actually is a, as part of CHEO, the Children's Hospital of Eastern Ontario, they do have an autism clinic, but then the transition out of that is very challenging because they don't really have psychiatrists to which to refer to. And I think a lot of psychiatrists are like, for instance, people in my position, a lot of them are very reluctant to take on the position of accepting those referrals because you are essentially operating on your own and you don't have the support of the entire multidisciplinary team that CHEO does have. So, and that I think also has to do with funding. And, I think that is something that we haven't talked about and maybe shouldn't start 5 minutes before the end of the topic, but that is also a very huge factor playing into it, I think.
Well, and I think the other part for people working in private practice, Agata, is around security issues, right? So at CPRI in 24 years, I've called Code White maybe twice, but certainly, things happen. And I think if somebody is aggressive and you're in a private office, that becomes a real problem. So we saw a girl the other week who I can't remember how old she was. I'm going to say 6 or 7, maybe. And at our first appointment, she actually required restraints in the waiting room because of what was going on. And I don't know how you would do that in a regular sort of outpatient office at all. And so I think it's not just the training of psychiatrists, although that's our topic today, but I think across the whole system, there's a huge problem. And I think that it's, the amount of money that ends up being sunk into people when people do spend a year or two in a general hospital is massive. And it's not just that, but also the block beds. At CPRI, oh gosh, I'm going to think 10 years ago now, maybe more, we had a boy who came to CPRI and was in the residential program for a few months, but he had been at sick kids in restraints in Toronto in a single room, I think for about 6 months prior to that, if not longer. And so again, the amount of time and energy and frankly expense devoted to that is enormous. And I think it's just, again, that lack of expertise, particularly when you come to more severe things like severe self-injury. There's minimal expertise anywhere. And those are people who really need that, that help from people. Are there any other questions or comments?
I don't see any other questions or comments.
So if I may, I will ask one other group that I won't put anybody on the spot, but I'm also always interested in finding out how things are done in other countries and where they might have different approaches to things. So I would say in England, for sure, developmental disabilities is a subspecialty, or learning disabilities is subspecialty in psychiatry. But if there are a number of people who are here today who are from other countries, if anybody wants to just chime in or pitch in about how things are, what the approach is in different places, I'd be really fascinated to hear that. I think, unfortunately, in less developed countries, there's obviously going to be far less services. I was in Guyana with Claire Mitchell, a pediatrician, a group of other people in 2019, and we were in one of the indigenous areas. So I don't want to say the middle of the rainforest, but it was literally in the middle of nowhere. And at one of our clinics, somebody had come. A woman had brought her son who had Down syndrome. So he was 5, had never been diagnosed with Down syndrome, which, clinically was easy to do, but was really hyperactive and very unmanageable, couldn't go to school, not that it would have been available anyway, perhaps. But I was asking somebody, and his mother was not a young woman. I was asking somebody and there were no other relatives. I said to somebody, what happens when his mother dies? What's going to happen to this boy? And this person said, unless the community is willing to look after him, then almost certainly he would die. Unfortunately, because there would be nobody else to look after him and his level of care, and which is sad to hear. But I think that, we are, I guess, fortunate that we have the resources that we don't have to worry about that, hopefully. But I'm just interested in if people have experiences in other countries of how these things are dealt with.
I can tell you about India. My limited knowledge about it is that those children who then become adults are looked after by the family members.
Yep.
And cared for by the family. They don't even have any specific homes where those children or adults go to. Things are changing, and I think as knowledge is, expanding, I think there will be changes coming. I do know about a couple of families of friends of ours who have children with developmental disabilities in USA, and the service that they get is very spotty because it depends on your insurance coverage. And one family has excellent insurance coverage and the other family does not. And they are barely surviving on the margins of, in terms of the poverty line. They don't have the insurance coverage, so therefore the burden of care is falling on the family because they don't have the funds to admit their children, who are now actually adults. They're young adults who have significant developmental disability issues, two adults, and they are parents that, and other extended family members are assisting and caring for them at home.
And that's and it's. I would like to think that, well, I was going to say that we're like the United States, but no, with the United States, hopefully we'll be more like us with healthcare. But it really does come down to that sort of thing. Although I don't know how Medicaid and Medicare work in the United States in terms of people with disabilities. But again, I think there's probably more available to children because that's where everybody puts money into that, but not into adults. So I had a patient, and I think the family would be, in fact, I'm sure they'd be okay with me sort of mentioning, I won't say names, but they were from Albania, or they are from Albania. And they moved to Canada before 2000. And there were issues with their residency, and there was the potential they were going to be deported. And they have a son who is very disabled, and 2 or 3 other children. And I was somebody I know who's from Greece. I was saying, which is just south of Albania, saying, what happens if this family gets deported back to Albania? What happens with the son? And this person was saying that there would be no services whatsoever. So mom would have to stop working. Probably one of the other children would have to stay home as well with this boy. And so it would limit everybody's ability to sort of, and their quality of life. And I think we can decry the lack of services here. It's obviously far worse in other countries. And it's something we need to think about as well, about how do we help, especially people coming to Canada who may not be used to those services and what their concerns may be.
True. All right, it's 10:20. Anybody else? Last call out to our audience members. If you have any questions or comments, please feel free to post them on the chat, the comments and questions on the Q&A board. Or you can raise your hand. Dr. Dzwonek, did you want to say something? No, okay, all right. Well, if there are no questions and no comments, I'd like to take this opportunity to thank you both, Dr. Nicolson and Dr. Dzwonek, for an excellent and robust, first of all, excellent presentation and reflections, especially Dr. Dzwonek and Charlene also, who was invited, as well as Dr. Nicolson for your very thoughtful presentation, which I think leads us to, mull over how best we can service this particular patient population and what do we need to do to improve our own skill set. So thank you very much.
Thank you, Verinder, for doing a wonderful job, and thank you for being you.
You're welcome. And thanks for completing the evaluation. Your feedback is very, very important. And I do also want to talk about, aside from the evaluation, if you can also bear with me, and we do have upcoming presentations coming. September 24th, Dr. Vasudev is doing MMI rounds. Miami rounds on September 27th. We have Mr. Michael Newman doing a presentation. We have a morning grand rounds by Dr. Mark Schechter. He will be talking about psychotherapy with the suicidal patients, an integrative psychodynamic approach. And we also have our ABC book club next week on September 17th. So look forward to seeing you at other CPD venues, and have a lovely morning. Thank you very much. Go ahead, Dr. Go ahead, Dr.
2 questions. One, what is Miami rounds? But you can email me at a different time and let me know. I'm hoping that it's a trip to Miami, but I suspect it's not. The other thing I just wanted to put a plug in. So last year, for a variety of reasons, which would irritate the hell out of me to discuss, and so I won't. We really had no educational things through the Developmental Disabilities Program, but we are with the recent hiring of Jason Wittes in the coordinator role. Our plan is to start up with the educational thing. So hopefully in October, November, we're going to start with our monthly developmental rounds again. So be on the lookout for that.
Thank you. Yes, and thanks for doing that. Those are excellent rounds. I love to attend them, so I can chat. I'm a very loud champion for those rounds.
Good, excellent. Glad to hear
Thank you.
that.
Yeah. Okay. Have a lovely morning
Okay,
and
thanks,
rest of
everyone.
your day. Yeah. Bye-bye.
Thanks, Verinder. Take care.
Bye.